The concept of conflict is neither good nor bad. Conflict is generally understood to be defined by various authors as a clash in individuals or groups' values, differences in beliefs, attitudes, and expectations. More than simple disagreements, conflict arises from a strong sense of feeling of incompatibility. It represents an escalation of everyday competition and discussion into an arena of emotional or even hostile encounters that can put a strain on personal and interpersonal tranquility or both. Conflict can be a strategic tool when addressed appropriately, and it can actually serve to deepen and develop human relationships. Some of the first authors on organizational conflict, for example, Blake and Moulton, claimed that a complete resolution of conflict might not even be desirable and may in fact thwart the stimulation of growth and change for the better. So why study conflict? Well, we needed to maximize strength within groups, to learn more about why individuals within groups choose or need conflict, sometimes more than others, and to produce better outcomes, including patient care-related goals. The learning objectives for this session are to use a model of conflict process to determine the nature and sources of perceived and actual conflict, identify conflict management techniques that will prevent lateral violence from occurring, and analyze risk factors for potential violence or disruption. Increasing our knowledge of the role stress plays within conflict is critical. Our society is known for being particularly stressful and stress-producing. We already know that stress leads to fatigue, which can lead to an increase in medical errors. Our culture within healthcare, furthermore, has been built upon a tradition of secrecy, shame, and blame when it comes to our failure to prevent medical errors. Gender differences exist and may at least partially explain why women are known for either avoiding or using compromise, and why men may be known for more aggressive techniques, none of which may completely solve a conflict. To understand the conflict process, we have to look at some factors. The longer ineffective actions continue, the more likely people will experience frustration, resistance, or even hostility. Let's begin with frustration. Remember, when people or groups perceive that their goals may be blocked, they feel frustrated. This frustration may escalate into a stronger emotion, such as when people become angry or just give up. When the patient does not carry out his or her part of the plan, we label this patient as non-compliant or non-adherent and feel frustrated that the patient is uncooperative, when in all likelihood, the patient had a completely different set of priorities at the start from those of the nurse. At the same time, the patient may view the nurse as controlling and insensitive. When such frustrations occur, it is a cue to stop and clarify the nature of major differences and make sure everyone is on the same page. Conceptualization is part of the conflict process. I like the idea of the snapshot image, for example. When we see or are confronted with something, our mind forms a mental judgment about what actually happened. Everyone involved has an individual interpretation of what the conflict is and why it is occurring. Most often these interpretations are different and involve the person's own perspective, which is based on personal values, beliefs, and cultures. Regardless, conceptualization forms the basis for everyone's reactions to the frustration. The way the individual perceives and defines the conflict has a great deal of influence on how creative those involved may be in trying to resolve the problem and what types of outcomes can come about. For example, within the same conflict situation, some individuals may see the conflict itself as very threatening and may label everyone involved as insubordinate and become so angry at the threat to his or her role that he or she falls back upon rigid adherence to policies and procedures. Others may view conflict as a trivial bickering and become critical of everyone involved, as in, we've been over this subject already, why can't you just drop it, and complain or withdraw. Such differences in conceptualizing the issue block its resolution. The leader has to get everyone to clearly state the conflict as I see it and how it makes me feel before they can define the conflict. For example, develop an accurate conceptualization together and proceed to resolve the differences. The action is, did you ever notice that once there is an accurate or agreed upon idea of what the problem is, the strategies, plans, and behaviors seem to just flow right on out? As actions are taken to resolve the conflict, the way that some of the or all of the parties conceptualize the conflict may change. The important point is that people are always taking some action regarding the conflict. Even if that action is avoiding it or deciding to do nothing, the longer ineffective actions continue, the more likely people will experience frustration, resistance, or even hostility. Outcomes are part of the conflict process. Outcomes is another word for consequences, or results from whatever actions were taken in any given situation. This conflict may be resolved with a new plan that incorporates the goals of two or more people to ensure that no one loses. Productivity and efficiency may increase, decrease, or stay the same. Emotions may be high, and anger and resistance may remain, resulting in further conflict. Bosco in 2004 used the term ugly to refer to attempts to downplay and pretend conflict doesn't exist. There are 4 strategies. Ugly strategy 1 is non-action. Did you ever come into contact with someone who pressures staff to smile and nod when asked if everything is okay because he or she doesn't really want to know? This is called non-action because nothing is really done about a problem and the leader doesn't want to hear about it. Such behavior can actually become part of the organizational culture to behave this way. Ugly strategy 2 is administrative orbiting. Another common way for managers to avoid conflict in the workplace is not to respond to it. They may actually ignore a colleague's attempt at a professional communication in voice emails or email messages, or make a habit of canceling meetings. Worse, if this behavior is known by his or her leader and continues, the avoiding behavior is said to be endorsed or approved. In another example, a leader may make mention of another team member's failure in a particular area while remaining silent about another's well-known transgressions, such as able to take time vacations first, always using schedules for his or her until late, and so on. Easily giving rise to distressing double standards. Ugly strategy 3 is secrecy. Another means of getting around conflict is having secrets. There are some managers who don't let people know where they are during the day. They might have plenty of so-called backstage discussions about, rather than with, the parties involved and play favorites, all of which amount to scenarios with a high potential for fueling, rather than dealing with the actual conflict in the first place. Ugly strategy 4 is law and order. A most unfortunate choice, yet one painfully recalled by anyone who has ever worked as a staff nurse, is a leader who relies on regulations, power, policy, and procedures. This is the person who can quote line and verse of policy, sometimes in quite a sympathetic tone of voice. Gosh, I'm sorry, but there's a policy that covers that, or even, we can't even go there. What would X, Y, or Z think of us? This behavior is destructive because it thwarts healthy discussion and challenges to the status quo. The manager who uses it most frequently thinks that by quoting line and verse, conflict will actually go away. The more the actions appropriately match the nature of the conflict, the more likely it will be resolved with desirably results. Let's talk about the case study on this slide. A well-known favorite was selected to work on a new patient satisfaction initiative. Terry has not produced any usable ideas and misses many meetings. When issues are raised by the team, they are told a lot of people are jealous of Terry's success. It is the physicians who are spreading these terrible rumors. Based on the information presented on the previous slide, which ugly strategy do you think is involved in this situation? Which behavior was identified in the previous scenario? The behavior is administrative orbiting. Were you able to pinpoint this avoidance? How is this behavior destructive to actual progress toward goals? How does this behavior actually contribute to conflict and stand in the way of a healthy conflict resolution? There are 5 modes of conflict resolution. These are avoiding, accommodating, competing, comprising, compromising, and collaborating. Avoiding or withdrawing is a very unassertive and uncooperative. Yet many times we choose to avoid deliberately, thinking that getting along or staying out of it is always the better option. Sometimes, in only some cases, it may be the preferred option. Would you like to give an example of what you have seen in the clinical area recently that could illustrate this point? The authors here say that we overuse accommodation smoothing behaviors. We tend to neglect our own needs, goals, and concerns, which is unassertive, while we try to desperately satisfy those others, which can be viewed as cooperative. This approach has an element about it of being self-sacrificing and putting ourselves to our needs last. Again, this isn't a bad thing unless it is done all the time to prevent conflict resolution. During competition, people may pursue their own needs and goals at the expense of others. Me first. Sometimes people use whatever power, creativeness, and strategies are available to win. Competing may also be a good thing, such as when standing up for your right to defend an important principle. For example, when we advocate for, say, staffing levels, defend a colleague, or try to expand financial resources for nursing education and research. However, people who are very skilled at competing may begin at some point to fail to hear the truth or not have much tolerance when others disagree or challenge them, even when they are wrong. They often react by feeling threatened, acting defensive or aggressive, or even resorting to cruelty in the form of razor-sharp remarks. We may as well call the Joint Commission on ourselves, "You've all done such a bad job, you better start writing the resignation letters," or well-aimed gossip or hurtful innuendos, which you see the outfit the consultant was wearing, helping the take her observations about her very seriously. Competition within work groups can generate ill will, favor a win-lose stance, and commit people to a stalemate. Such behaviors force people into a corner from which there is no easy or graceful exit. A damned if I do, damned if you don't form of double bind, which gives rise to unfortunate culture of the so-called shame and blame mentality. Another example is when someone realizes they might not win, as in the case of the poorly ranked candidate for a position. So they quietly sabotage their own colleagues' best efforts to be sure that nobody comes out ahead. I realize that I might not be your choice for this position, therefore I am recommending that you consider only applicants from outside the organization. Compromising or negotiating involves assertiveness and cooperation on the part of everyone. It requires maturity and confidence. It is a learned skill that is developed over time. A give-and-take relationship results in conflict resolution, with the result that each person is able to meet his or her most important priorities as much of the time as possible. Compromise is often described as a middle ground, and the successful leader invites everyone to join in. This is the preferred means of conflict resolution during union negotiations, in which each side is appeased to some degree. In this mode, nobody gets everything they think they need, yet there is a sense of energy that is necessary to build important relationships and teams. Compromise supports a balance of power between self and others in the workplace. Collaborating is the opposite of both avoiding and competing. It is the most creative stance. It is both assertive and cooperative because people work creatively and openly to find the solution that must fully satisfy all important concerns and goals to be achieved. Collaboration involves analyzing situations and defining the conflict at a higher level where shared, superordinate goals are identified and commitment to work together is generated. Please see the box 2212 on the slide. For example, when nurses and physicians work together, they can collaborate by replacing the statement, "I'm in charge with." What is the best thing we can do for the patient and family right now? How does each of us fit into the plan to meet their needs? This requires discussion about the plan, superordinate goals, and how it will be accomplished, and who will make what contribution towards its achievement and proposed outcomes. The same scenario fits for patients and families. There are many things to think about and consider when selecting an approach to resolve conflict. Nature of differences, underlying reasons, importance of the issues, strength of feelings, commitment, and goals involved. Preferred and previously effective approaches can be considered, but they need to match the situation. Not everyone has the same experiences nor the memory of the same conflict. Sometimes a third party may be introduced into a conflict so that mediation can occur. Mediation is a learned skill for which advanced training and/or certification is available. The mediator is usually an impartial helper who assists each party in the conflict to better hear and understand the other. Mediation is not so easy. In our American society, for example, there is much focus on who can control whom, and a lot of emphasis on winning. The successful individual involved in conflict resolution and negotiation often moves beyond winning and even beyond avoidance, accommodation, and compromise, which are more about trying not to disturb the status quo. In the nursing practice arena, there is often the added difficulty in negotiating conflict when at least one of the parties, which has historically between the physician when it comes to quality of care issues, is viewed to be or view himself or herself as an unequal or uneven playing field. The objective of polarity management is to get the best of both opposites while avoiding the limits of each. In other words, once people determine their conflict is a polarity, they can act to maximize both poles' upsides and minimize both poles' downsides. This is called polarity management, which requires a shifting focus from pole to pole when the leader, acting more as a coach in these instances, sees that there are some downside consequences about to occur. The key, just like for a coach in a football game, is to sense oncoming negative consequences occurring. The key, just like for the coach's football game, is to sense oncoming downside consequences, or to be sensitive to feedback that there are negative consequences occurring. Then take action toward the opposite pole. Let's review this case study. Todd Johnson's task is to introduce key elements in the Saving 100,000 Lives campaign at the IHI institution. Half of the team report to the nursing department, while the other half report to the various vice presidents and physicians, with all sides blaming each other for recent failures. To maximize support, it is important to illustrate that no one plan is right. With a diverse group, Todd ought to acknowledge contributions unique to each member. Both and rather than either or language should be used. Keep in mind that difficulties are certain to be ongoing, and this should be an expectation. Ongoing assessment strategies for success include understanding your own approaches to conflict. Conflicts may be resolvable or unresolvable, and they are common in healthcare and when dealing with people in everyday life. To resolve conflict, we need to identify differences, priorities, and common goals. We need to determine which approach to conflict is most appropriate, and last, we need to act in that way to resolve it. When conflicts involve polarities, all parties need to analyze their structure and dynamics, identify ways to shift emphasis among opposite poles, and partner with others to bring about the most satisfactory conclusion. Finally, we need to recognize that people who occupy leadership positions on our institution's table of organization may not be the best people to demonstrate or coach us in conflict management. We need to understand and recognize that very often our leaders exist within other settings as well. Have we considered our professional organizations or specialty associations as places to go to link up with nursing leaders? In conclusion, learning about conflict is actually a lifelong journey. None of us is perfect at handling conflict all the time in every situation. Therefore, we all have something to learn. So one of the expectations of professionals is that they know how to delegate work in such a way that they are effective and more work is done in a timely manner. That is what we are about to look at now. There are several things to consider when making a decision about delegation. They can all be summed up in these questions: why to do it, when to use it, and who to delegate it to, how to do it, and what to consider in the delegation. The biggest question to answer is, why delegate? If you are able to accomplish all of your work in a reasonable time, why would you want to delegate it? Some possible answers are to spend more time with patients, to use time to research best practices, to make time available to work with other challenging patients, to increase skills in holding others accountable, and in communicating what is needed for patients. Few positions exist in most healthcare organizations where delegation isn't a needed skill. When should you use delegation? Obvious times to use delegation are when you clearly cannot provide all of the care to assigned patients. When the delegatee is highly competent at various tasks that represent a portion of the care your patients require, or when you are ensuring care for another group of patients, such as when a colleague is away from the critical unit. Basically, registered nurses work with two types of people to whom they can delegate nursing tasks. They are licensed practical or vocational nurses. They are called different names based on the state of practice. And unlicensed nursing personnel, who are also known by various names. Remember that the delegating professional remains accountable, and that person cannot delegate a patient to another. You can only delegate a portion of the care. As a result, knowing those with whom you work is really critical to successful delegation. Who do you delegate to? There are several important facts and views to consider about the person to whom you may delegate something. The best two indicators to start with relate to what the organizational policy is regarding delegation. If the organization makes clear through policy that delegation of certain tasks is unacceptable, it is important to know that before you are in a situation where delegation is possible. The next thing to know is what the position description for the given person is and if there are any exceptions. For example, an LPN or LVN might be in a clear position description, maybe in an assistance program and unable to administer medications, even though the position description may indicate that such is possible. Some institutions provide great detail about tasks unlicensed assisted personnel may perform. Other institutions speak in generalities about performance. Next, it is important to know how specific individuals perform and what other responsibilities they have. You won't be delegating to a position, you will be delegating to a person. Once you know that someone is trustworthy and available, the next thing to consider is the individual's knowledge, skill, and attitude in relation to the tasks you are assigning. This does not mean that you will assign only those tasks that someone else wants to do. What it does mean is that you may need to provide greater supervision for some aspects of care. If you are working with an individual who is assigned to work only with you, you know what that person is involved in, and you can convey what to report throughout the day. If you and others are working with an individual, you may need to negotiate with someone else for time when the individual delegatee can work with you. It is not likely that the person will be communicating with you throughout the shift because he has many other people whom he or she is working. If such is true and you really need help monitoring a particular patient, ask the delegatee to call you immediately if he or she notices specific behavior while passing by this patient's room. In this way, you are expanding the watchfulness for a particular patient, even though there is insufficient assistive staff to work directly and only with you. What should you consider when delegating? Things to think about include the following: how long the person has worked with the specific patient population, whether this person is an organizational employee or a contracted employee. What is happening in the larger context of the person's life? Is delegation safe for the patient? Remember that the bottom line regarding delegation is safe patient care. Delegation happens differently in different organizations. For example, in the hospital ICU, where staff may be more stable and most care is visible from many vantage points, delegation is easy to implement. The delegator can see what the delegatee is doing. In a community clinic, however, the number of professional staff may be very limited, and the opportunity to see what any one delegatee is doing is unpredictable. In this type of situation, it is very important to know what the skills and abilities of each staff member are. Proper delegation has many benefits for nurses. Delegatees do not substitute for professional nurses. They do expand the nurse's availability for the work that only registered nurses can do. It is both a time-consuming and time-saving strategy.